Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Christopher Stadtherr is a board-certified physician in family medicine and obesity medicine with expertise in nutrition and metabolic health. Dr. Stadtherr has been committed to improving the management of diabetes in the hospital setting, with success in reducing glucose levels and insulin requirements for patients, often achieving dramatic results even in short hospital stays. While working as a hospitalist, he served as the principal investigator on an inpatient study of the nutritional management of diabetes in a hospital setting, and continues to closely follow nutritional research. These efforts with nutrition and lifestyle modifications have renewed his enthusiasm for practicing medicine and continue to be rewarding by being able to help individuals to reverse their diabetes, improve their metabolic health, and avoid the myriad complications that necessitate hospitalization. Outside of medicine, he enjoys spending time with his wife and two daughters. Some of his many interests include music, strength training, traveling, outdoors, backpacking, water skiing, juggling, home improvement, and raising backyard chickens. You can find him at www.revitalizemetabolichealth.com. Dr. Stadtherr, what an absolute honor it is to welcome you to Boundless Body Radio.
All right, thanks a lot, Casey. Glad to be here.
It is awesome to have you. I was so glad to meet you a few weeks ago at Low Carb Denver. I am going to say that already you're starting out with a very low amount of clout with us. You said you're from Minnesota and you've never played ice hockey and you've never gone ice fishing. What is up with that?
That's correct. Don't have much excuse for that, but I enjoy all things Minnesota. Actually, it's just it's unique that I actually grew up a whole mile away from a really popular sporting lake, and I'd never been on it as a kid.
Wow.
But in all fairness, my parents had a lake property up in Wisconsin, so I spent my summers up there. That's where I got my water fun.
That's amazing. So my wife also has a family cabin up in northern Wisconsin. I'm not sure where yours is, but that is such a beautiful area of the world during the summertime. Absolutely amazing to go water skiing and to spend time on the lakes. It's just incredible there.
Yeah, it makes the bug swatting worth it.
Dude, bug swatting, that is serious. I remember people telling me, like, you have to take the bugs really seriously in Wisconsin. I was like, nah, not that big of a deal. Like, I don't really love to use chemicals or whatever. Dude, 5 minutes exposed out there was like, you got eaten alive. You have to take that super serious.
Oh, yeah. Mosquitoes, the Minnesota state bird. I don't know if you've heard that. That's a fact.
I believe it. In the lake they have. No, that's fantastic. It's cool that you spent time up there. It is a wonderful place to enjoy the outdoors. And yeah, it sounds like you were active in all kinds of other things besides ice hockey and ice fishing. You said you were a scout also growing up.
Oh, yeah. Boy Scouts all the way. And then kind of melded into the Explorers group. There was a Healthcare Explorers group, which is actually a division of the Boy Scouts, but not limited to boys. So that was kind of cool, but yeah, all things, sports. I was big in baseball, basketball, soccer, etc. I was busy. And then when school came around, that was really my focus. I was a very serious student, and all sorts of AP classes. I went to a college prep high school, in fact, I get a load of this, all male, military. College prep high school. It was intense.
I'll bet that was pretty serious.
Yeah. It was great. It was perfect for me. It gave me the focus. It allowed me to focus, and I was really hell-bent on going big academically. And wow. So it was a good jump start on college, and I loved it. Wow. Wouldn't trade it for anything.
Wow. And you're also a Golden Gopher, right? You went to the University of Minnesota, at least for part of your schooling.
That was only med school. So I don't really identify as a Gopher, but
gotcha.
I did undergrad in Iowa, Cornell College.
Gotcha.
Small school, and then so known for their one course at a time calendar, which itself was really cool too. And then back to Minnesota for medical school.
Yeah, gotcha. Did you always know, that you wanted to be a doctor?
So probably about. My best recollection is it was 9th grade. I remember doing the job assessment exercise, and it didn't come out doctor. Right? If I recall, it was something stupid like lawyer. No offense, lawyers, but I think I would have died of boredom. But then that year, I remember it evolved. I became really fascinated by life sciences, biology. My mother was a pediatric ICU nurse, so I was always surrounded by these medical textbooks, nursing textbooks, etc. And so just developed a fascination about the human body from that. And that's when my interest in medicine really picked up. It was that 14, 15 years old.
Yeah, gotcha. Pretty young. So when is it in your schooling and med school that you have to decide on something to specialize on?
So the first 2 years of medical school are pretty standardized. You're learning the physiology, then pathophysiology, all the disease processes and so on. And then in your third and fourth years, aside from the standard core rotations, you're allowed to choose some electives. So it's over those third and fourth years where you better have it figured out so that you can prepare for the residency of your choice. So really, it's during the first and second years of medical school when you start doing some rotations with community docs and so on, you start getting a sense of what's interesting. But that's the key time is probably second year of med school. You got to figure it out.
Yeah, so you don't have a long window to be able to sort that out. What began to interest you as far as like specialization? Excuse me.
Yeah, well, starting to follow docs in their clinics, just the community docs, whether it's a family doc, internist, pediatrician. There was a big focus on primary care in medical schools because that's always such a huge need. And just spending the day with them, every single day I did that, I was totally in love. Like, yes, this is for me. Everything was the best thing ever, right? So it made it difficult, of course. Like, oh, peds, love it. Go see adults. Oh, adult medicine, love it. And then family medicine. Oh, I can do both? You're kidding me. This is great. Ultimately, I decided on family medicine because to me, that's the picture of a real doctor. The jack of all trades. For example, I always had this little scenario in my head of, if I'm sitting on an airplane and there's an emergent need for a doctor, I don't want to be that ridiculously specialized doctor who has no clue how to help someone in a time of need like that. And so I wanted to be the doctor who had that breadth of skill, that skill set that could serve anyone at any time. And little did I know, once you do family medicine, for example, the world's your oyster. You can pretty much go any direction you want.
Wow.
There's limitations. Obviously, you may need more training to do some things, but you can really do some pretty exotic things. You can work on a cruise ship. You can go work in rural Alaska. You can go work around the world in remote areas. There's a need for those skills everywhere.
Yeah. So interesting. So with all of those skills, when I think of a family physician, I think of like a clinic setting. It could be down the street in, maybe a strip mall or something. It's different than thinking about family medicine being practiced at a hospital, but you ended up practicing at a hospital. Is that correct?
That's correct. Yeah. So outside of residency, or after my residency, my 3 years residency, I decided to join a group practice, a family medicine clinic. This was in suburban Minnesota, and loved it. It was great. I got to practice full spectrum family medicine from cradle to grave, to deliveries, peds, OB, adults, inpatient, outpatient, did the works. It was great. That was basically my dream job. And then things were shifting at that time. So this was the mid 2000s, and there was a trend towards outpatient physicians, community physicians, primary physicians, turning over their inpatient practices to the hospitalist teams and focusing instead on the outpatient care only. And really, it was driven by financial pressures of the fact that you can be more productive if you just focus on only the clinic, rather than starting your day in the hospital rounded, then driving to the clinic, and then fielding phone calls all day and potentially having to go back to the hospital at the end of the day. Whereas if you just focus on the outpatient only, all right, you just hammer out a bunch of patients in the clinic without those interruptions. that's a benefit financially for the clinic. But my partners put up with me for quite a while. I said I don't want to leave the hospital, and so they stuck it out. They didn't want me to leave, but then, the writing was on the wall. It was becoming more and more clear, and so ultimately I decided, all right, I'm going to go become a hospitalist instead. And so, yeah, it's a little bit unusual. There's of the hospitalists, I mean, probably 10%, 15% are family medicine docs, but we have the breadth of skills to do it, and you get in and do it full time. You learn the skills, you pick up the skills just as if you'd always done it. It's really no different than the internal medicine trained docs that make up the bulk of the hospitalists.
Interesting. Wow. Okay. So I think, if I'm not mistaken, it's only Dr. Eli Jarouge, who we've hosted on our show, who has been a hospitalist. And I remember asking him what that is. Can you define what a hospitalist is and what that job entails, essentially?
Yeah, basically a hospitalist is a physician who specializes in hospital-based problems. So any type of medical issue that might land a person in the hospital, that's our domain. And so basically once a patient gets admitted through the emergency department, the ER says, all right, this person's sick enough to need to be hospitalized, then the hospitalist team takes over. And until they leave the hospital. That involves, being the attending, basically. So overseeing all the care that a patient receives in the hospital, coordinating the specialists, and doing the daily management of whatever problems arise. And so it requires a very broad set of skills that's typical of the primary care trained physicians. And then it requires knowing your limits. When do I need to bring in a specialist for assistance on a particular problem?
Wow. Well, you mentioned it a few times, a broad level of care and skill, and it certainly sounds that way. What things, how do I phrase this? Did you treat different things as your career was moving on, or was it pretty much the same kind of stuff that you would normally see, anything that comes into a hospital?
Yeah, it was always a general broad situation. I never really had a focus until my recent departure from the hospital. So no matter what came in, I had to deal with it. That's just the nature of the job, because we didn't specialize on particular problems. Now, everybody over time develops particular interests, and so for example, at some point, I became particularly interested in the metabolic disorders, diabetes, et cetera. And so when those patients came in, I was particularly skilled and adept at managing those patients because that was my big interest. But it's still dealing with anything and everything as a hospitalist.
Yeah. So how did that interest in metabolic health start to materialize? Can you compare like the kind of care that you were doing before being interested in that to, what kind of evolved for you to I guess practice in a different way?
Yeah. So this was back in it was 2014. I was part of this emerging leaders group with my employer, basically developing hospitalists into becoming leaders for their teams. And one of the assignments was find a performance improvement project. Like, oh man, that's a huge undertaking. To find something that I want to spend all my time on for the next several months had to be good, right? And nothing at the time really stood out. So I said, all right, I'm going to go to work this week. I'm going to pay attention to something that pisses me off. What pisses me off about the way the hospital works? And that could be a good project. So here I am one morning reviewing this patient's chart, diabetic. He's on insulin. I don't remember why he was there. It doesn't even matter. He was acutely ill. Looking over his glucoses and consistently 200s, 300s. I'm like, what the heck? We're throwing insulin at him, all the sliding scale insulin, which is the default approach in the hospital. And so I walk in the room, and this was shortly after, or sometime in the mid-morning, and he had just finished off his breakfast. Giant plate from a Belgian waffle with syrup, with side of fruit, orange juice. And I just lost it. Like, dude, what is going on here? What did you really just eat that whole waffle? He's like, well, yeah, they gave it to me. I'm like, your diet are you on? Well, they said I'm on a diabetic diet. So I storm out of that room and get into the chart. Like, sure enough, it's got the diabetic diet order. So I call down to the cafeteria. I'm like, hey, what's going on here? Why did my patient just have an entire tray full of carbs on his diabetic diet? I'm like, oh yeah, well, he's allowed 60 grams of carbs per meal, and that falls within that range. So like, no, this is so wrong. And so that was a big turning point for me. So that launched me into doing a ton of research and looking into why is the diabetic diet as it is? Why is that the standard of care, especially in the hospital? And so took me into reviewing all sorts of treatment guidelines as well as the dietary guidelines. And this is when I discovered, people like Eric Westman, and I met him at the Low Carb Denver conference and basically told him he was the reason I was there. Coming across his research paper, that just shapes my path. And so diving into this research, kind of the pioneers in the low carb field at the time, and that became my performance improvement project and ultimately the direction of my career. So I put together all this research. I formulated this argument for why we need to fix the approach to managing diabetes in the hospital, specifically with just that simple nutritional intervention. And I took it to a couple committees that were relevant to that in the hospital, and proposed this performance improvement project. And that's where fireworks went off. Got all sorts of flack from the nutrition department, especially. The dietitians railed against me. There was very little support. I will say that there's an intensivist / pulmonologist who was on that committee, and that's where I got the most support. He was a very serious evidence-based guy, and he's like looking at it and says, well, yeah, I see their logic in this. Let's see what you can do with it. So he offered low-level support, but I really never got the support I needed to make this a big project. And ultimately it just faded away. And so I did my best to scour up some data. I kept track of patients I saw, and I did a little analysis of the data from the patients that I had. Best I could do, because it was all on my own. And the data looked really good. I tracked my patients on the diet, and I also tracked a little cohort of standard patients. Obviously biased to me being the only one working with those patients. But along the way, I got some of my colleagues to appreciate the value of it, and still to this day, some of them are using the strategies that I did. One of the big outcomes from that, one of the big victories, small victory, but if you understood the hospital system, I think it's actually quite a big victory, is it resulted in putting a new default, but not a default, a new option, a button on their Epic order. So in the Epic electronic record, when you select a diabetic diet, the default was 60 grams per meal. And then there was an option for 75 and an option for 90 grams per meal. Yeah, exactly. Outrageous. And so I proposed, not crazy aggressive, I proposed a 45 gram restriction. That way they had some flexibility. It allowed them to order several different things still, but it would make a dent in their glycemic control. And so ultimately I got them to put a 45 gram button on the order set, and it remains there to this day. So that was one of small, big victories, if you will.
Wow. Wow.
Yeah.
That's amazing. So what is 45 grams in a meal? That to me is like 1 cup of cooked rice. Is that right?
Yeah, perhaps a little more than that. So to give it, a slice of bread is approximately 12 to 15 grams. I'm not sure about a cup of rice exactly. That could be pretty close.
Okay, so you were successfully able to lower recommendations per meal if somebody wanted to from 4 slices of bread down to 3 slices of bread
That's
per
one way of
meal.
looking at it.
Wow.
Yeah. Yeah, it's not that aggressive. Yeah, exactly. It's not like I'm depriving anyone.
Right. I was going to ask, like, what other like egregious things did you propose? That's not even that big of a deal.
Oh, that was it. What I did was I proposed the 45 gram restriction. And mind you, I was only proposing a pilot study. This is not the default. The default to this day remains 60 grams. All I proposed was, let's do a pilot project. Let's see if this makes a difference. Because if it does, then maybe we take this bigger. And wouldn't we want to improve patient care? Because we know that high glucoses are associated with worse outcomes, worse recovery, poor wound healing, increased infections, all of those things, right? So I was just proposing this as, hey, if this shows good data, the hospital should love this and run with it. And so it was just a short-term, very limited study. It was only on 1 unit out of the 10 units in this facility. So I proposed the 45 gram restriction. And the only other thing I did was I created a separate menu for these patients, the eligible patients, so patients with type 2 diabetes. Basically reasoning that, like, all right, if we're going to tell them you need to restrict your carbohydrates, don't show them the shiny thing and then tell them they can't have it. So don't show them the standard menu that's full of crap and then tell them they can't have it. So let's just give them a smarter menu and allow them to choose from the better choices, the lower carb choices. Yeah. I also reasoned, if the hospital is serving something, the patient has the impression that that's healthy, that that's a good choice. Like, hey, I'm diabetic and the hospital gave me Fruit Loops this morning. Those must be okay to eat when I'm at home because the hospital gave it to me. They're the authority. In fact, I've had several patients comment to me about that too, saying, well, they gave it to me, should be okay to eat, right? And it puts me in a bad spot because then then it's me versus the hospital saying, oh, well, here's why that showed up on your tray this morning. I'm sorry to give you this mixed message, but here's why you don't want to eat all those carbohydrates, etc. In fact, I had talked to this one guy a couple years ago. I told him about my thoughts on the diet and controlling the sugar and so on. And the next morning, I come in and he tells me what's on the tray and he makes the comment, Doc, they might as well have just brought in a pack of cigarettes for me. That's how bad that meal was. It's like, yeah, man, you have a point. And
wow.
so that's the power of those little things. The hospital says it's okay by the fact that they put it on my tray. And so my approach was create this list. In fact, I made it a tear off list so that they could even take it home. And it showed them good examples of food that were, or of meals that were more appropriate for their diabetes. So I made it an education piece too.
Wow. So what did those meals look like? Like, what were you recommending instead of the Fruit Loops?
Yeah. So basically it was just cutting out the simple carbs. It was, here's a meal without the toast. Here's a meal with smaller servings of potatoes, perhaps, or eliminated the breakfast burrito minus the burrito. It was, instead of the chicken sandwich or the burger or the deli meat sandwich, it was have the fillings. In fact, I don't care. Order two chicken breasts, 2 burger patties, no bun. So taking away some of the sides, just eliminating the high carb, simple sugars. And so it was really just focused on the more or the higher quality ingredients and,
Wow.
and formulating meals that were still appetizing without the high carb load. So it didn't look that different. It was just simply get rid of some of the sides and be smarter about serving sizes and so on. Because I still had to work within the limits of the hospital as far as what they were able to pump out of the kitchen. And so I had to be strategic about it. And it was a delicate process of, here's my proposal. What can they do? They can look at it and say yes or no, we can't handle that or whatever. And so it's pretty tedious getting all of that squared away.
Wow.
Now, unfortunately, I'll tell you that I still have a foot in the hospital. I still pick up some shifts periodically, and the quality of food service has declined significantly. It's terrible.
Worse now?
Oh yeah, far worse. Yeah, and we can blame a lot of things on the last 3 years, financial stresses and so on. And food is one of those things. It's a big cost, and a lot of food, unfortunately, goes wasted in the hospital setting. You bring a meal to someone, they're, I'm just not hungry, and it gets thrown away. It's like, okay, I understand you're not going to fork out a ton of money on the food, but maybe we could be smarter about it. Offer higher quality ingredients in the hospital. It was a big battle of mine for 10 years.
Wow.
It was frustrating.
Wow, that would be immensely frustrating. How was your advice on changing some of these meals being received, like practically from the patients? Did they revolt against you when you said, you shouldn't have Fruit Loops and maybe you could have 2 chicken breasts? Like, was it a terrible thing for them to adjust to?
Not at all. All it took was a little bit of education, and they were rallying. Said, yes, oh my gosh, doc, you're the first person to ever talk to me about this stuff. You're the first doctor to ever even mention nutrition. Heard that all the time. And once you explain the basic science behind it, just the basic physiology of carbohydrates break down to glucose, and that raises the glucose in your blood. They get it. It didn't take much. And so it was just a matter of proper education. Now, of course, in the hospital, I have a captive audience. They're stuck. They're in a desperate position. They're willing to try almost anything, and I realized that. But they were very in tune to what can I do without medication to improve my diabetes. Everybody wants that. I at least that was the impression I had, at least the people I was working with. And granted, there's always some patients who just don't care. They're very careless, self-neglectful. But when patients learned that, hey, I can make a huge difference in my health by making some simple changes in my nutrition, they loved it. And they were very excited to implement these changes. I mean, I'd have families coming in like, hey, I want to hear what this doctor's saying. And so the next day I'd have to do an abbreviated spiel and repeat some of the same things I was teaching them, because they were all on board. Like, hey, mom, dad, we're going to get you fixed up here. I'll take over the cooking if that's what it takes. So people were very excited about this idea of diet matters, and the healthcare system never broached that topic with them.
Wow.
That's the sad thing.
That's so interesting. It's like when you and I talked the first time, you were featured in our podcast episode where we talked to lots of different attendees from Low Carb Denver, and I really appreciated that conversation with you. We had a short chat, but we made the point that like most people would see obese people or diabetic people and just think like, this is obviously their fault. They're screwing themselves up. They don't really care to get better, clearly. again, I made the point then, I'm going to make the point now. That is not the case that I'm seeing out there. People do care a lot and they do want the right information, and they get really frustrated when they feel like they're following the right information and it doesn't work for them. So it's really encouraging to hear that these people really wanted the help, were open to it, even though it was like a more unconventional message.
Yeah, absolutely. Yeah, it was very reassuring to see people respond to that favorably. And it really convinced me that, hey, this is a service that people need. And as a hospitalist, though, I was stuck in this, one patient at a time position. And, I could make a big difference for that one person. But it felt like the system always made it more difficult. There's always changes in the hospital, increasing demands, less time to do our work, and it just wore on me. So now I make this sound depressing.
It would be very depressing. It reminds me of my personal training career when I was trying to help people by telling them to eat lots of vegetables and nobody could do it. And it's like, you feel like you're giving all these people the right advice. They're failing. So it's clearly their fault. It has nothing to do with the advice, which is the best. And you don't understand why nobody can get to their goals, save the facts that these people can't listen to you enough. It's very, very frustrating. It's sad.
Yeah. And people do look up to all of these authorities, whether it's the government and the dietary guidelines, whether it's the American Diabetes Association, whether it's whatever the hospital serves them, or what the diabetes educator tells them. That's all they know. For a lot of these people, they come from a very simple educational background, and they're not good at sorting through the BS. Like many of us in this low carb community are, or other scientists, so on. So when they hear something about, well, this is the guideline, this is, government says this is what to do, they latch on because they don't have the wherewithal to appropriately evaluate that. How valid is that? And so then I worked hard to give them that background information of, all right, there are different ways to do this. And I'm not asking you to eat carnivore, although some people get that impression, right? Like, you can do this vegan, sure. I don't know how sustainable it is. Well, I do know it's at some point it's not because of micronutrients, but this doesn't have to look any part. I'm not telling you how to eat. I want you to understand that the key part here is what you don't eat, right? Avoid the carbs. You can make a huge impact. And beyond that, you can do whatever you want. Eat plants, eat animals, I don't care. So I always worked on helping people understand that there are options, and they loved it. They really felt like someone was finally addressing this problem that had ruled their life. Because once you're diabetic and you're injecting insulin and worried about your glucose all the time, oh man, that's consuming.
Yeah,
it's just an exhausting way to live.
Yeah,
they needed the hope, and they ran with it.
Wow.
Yeah,
that's amazing. Okay, so I'm not sure what like the average hospital stay you had experience with these people. I don't know if it's like they were there for a week, they were there for a month. Just generally speaking, I asked you about the practicality and whether the patients would even accept your advice or be open to your advice. What about the results side of things? And what I would assume would be a fairly short amount of time in a hospital stay. What were the actual like results that you were noticing for people? Were you making a massive, huge difference? Were you making a small difference? Were the numbers a little better, a lot better? Like what things were you observing?
Yeah, so the length of stay was quite variable, and this is the big thing. Hospital systems have a singular focus on shortening the hospital stay. At this point, they're trying to spend the least amount of money, so that's a constant battle. So, anyways, we were incentivized to keep the stays as short as possible. So anywhere from overnight stays to, weeks, sometimes months, although those are exceptions. But average stays were probably 3 to 5 days.
Okay.
Was the bulk of it. Enough time to deal with an acute issue, make sure they're stable, and then get it back home. And the effects of modifying their diet could be seen pretty rapidly within a day or two. And this became really apparent when I started tracking all that data. I was pulling up these charts and logging every single glucose and the times. And unfortunately, there's a lot of variables in the hospital. Insulin use, steroids, like prednisone that increases glucose. I actually excluded those patients, as well as patients who are fasting for more than 24 hours. It's like, all right, those are, I don't want it to look like that's why their glucose was lower. So I would exclude those, some of the exceptions. But generally within about 2 days, there was a noticeable improvement in their glucose and less insulin need.
2 days.
2 days. 2 days. Yeah, absolutely. And, it's complicated. There's a lot of moving parts in the hospital. And so some of that could be from the fact that when the patient came in, there was a lot of acute stress, and that'll drive the glucose up. And so naturally the glucoses are going to level out a little bit. But also keep in mind, I was comparing my experimental group to a control group, although again, it wasn't the most rigorous science. But I did have that comparison group. And it appeared that there was a significant impact. Also, not only just reducing the high hyperglycemia, the high glucose, but also there was a marked reduction in the hypoglycemic events, the low glucoses, because we needed less insulin. And insulin is really dangerous, especially in the hospital when there's all sorts of things going on. There's just too many moving parts for insulin to be safe in all settings. It's basically are you familiar with Richard Bernstein?
Yeah.
The
type 1 protocols, right?
The type 1 protocols, and he has the law of small numbers, which I think is a very valuable concept. So the smaller the change you make, the smaller the change you'll see, the smaller the effect. And so instead of walloping people with 60 grams of carbs followed by 15 units of insulin, and you may have a dramatic swing, hyper, hypo, let's give them 45 grams of carbs, and maybe they only need 10 units of insulin. You're much less likely to have a life-threatening event of hypoglycemia. So the law of small numbers is a really valuable concept to apply in that situation.
Yeah. And not a lot of people talk about the risk of having really high blood sugar, really high insulin. Those things are not innate in your body. Just because you took insulin to cover the glucose doesn't mean that your glucose going sky high didn't cause damage when it was really high. It's a huge problem.
Oh, definitely. Yeah. Wow. I argue, as I always have, that insulin is the absolute worst way to treat type 2 diabetes. Because type 2 diabetes is a state of high insulin. It's hyperinsulinemia, it's insulin resistance. So just like if somebody's fluid overloaded, what are you going to do? Give them more fluid? No, you're going to give them a diuretic. You're going to take it off. If they have high potassium, are you going to give them more potassium? Heck no. Kill them. So if they have high insulin, are you going to give them more insulin? Well, of course, that's what we do.
Yeah.
That's great. Care.
No, I'm going to start a clinic treating alcoholics. And my idea for treating alcoholics, that they can't get a buzz on the alcohol that they're having, let's give them hard liquor so that they can continue to get a buzz. I think I'm going to be rich. It's a great idea, I think.
There you go. Yeah, it's pure nonsense. And yet that's the standard of care, and people don't get it. And in fact, even more nonsensical, there's a standard of medical care for the hospital setting published by the American Diabetes Association. And they get updated every year, every other year, whatever. And the standard of care in the hospital setting is to stop all oral diabetes medications on admission and switch over to insulin. That's it. Simple as that. Because now, so this is built into the electronic records. So when I try to reorder somebody's metformin, I get hard stops and it's prompts built into the electronic record. Are you sure? Are you sure? Does the benefit outweigh the benefit or the risks? Did you talk to the pharmacist? Did you adjust the insulin? I mean, you have to answer all these questions just to order metformin. The first line treatment for type 2 diabetes, because it's in the hospital setting, and it's not the quote unquote standard.
Unbelievable.
Yeah.
Unbelievable.
Yeah.
Wow.
So then I have all these, these younger colleagues who fresh out of training or they're just, it doesn't even have to be younger colleagues necessarily, but other hospitalists who just drink the Kool-Aid on this stuff. There'll be a patient sitting in the hospital for weeks, let's say. They're fully recovered. Now we're waiting on some other ancillary studies or some other piece to it. And they won't restart the metformin because that's the standard. We should keep them on insulin. I'm like, you moron, put them back on their home meds. I mean, what's the difference between starting their metformin now or tomorrow when you send them home? It's just a pure arbitrary designation, right? And so this kind of stuff, people think, oh, well, doctors can override the guidelines. Yeah, but this is what happens, is that they're uncomfortable doing so because it's not the standard of care. And now they feel like they're doing something cavalier.
Yeah. Wow. Okay. Just on a practical, from a practical point of view, you're saying that the priority of the hospital is to get people out of the hospital, discharge as quickly as possible. It sounds like you found a way to be able to do that, I would assume, with being able to improve patients' numbers. I would assume they would be able to discharge a little bit quicker. You're doing something that the patients were on board with. They understood, you explained it, that they enjoyed it, in fact, and they loved having the education so much that they might have brought in their families and tried to continue doing what you were recommending when you were at home. Is this hospital system, why is it not named Dr. Chris Stadtherr? Like, why do you not have a national holiday with your name on it? Why are we not throwing parades, annually for you? I don't understand why this isn't celebrated.
I'm unpopular with administration.
It's crazy.
You know what? Part of my goal was to get that data as far as, does this improve length of stay? And so admittedly, I don't have it because I wasn't allowed to get enough data. I didn't have the support for it. But that data exists, actually. There's research from decades ago that shows improved glycemic control during the hospital results in a shorter length of stay. So I'm trying to sell the hospital on this point. And I gave them a tool like, all right, if you guys want to lower length of stay, we should look at improving glycemic control. If you want to lower glycemic control, or improve glycemic control, here's how to do it. And the cheapest, simplest, safest way possible, right? I don't want to use a ton of insulin. That's dangerous. You hit lows. But I'm giving you the simplest way to do this. And they didn't buy it.
Using the cafeteria rather than the pharmacy.
Right. Something they already have. In fact, we'll actually save you money. You won't have to buy as many loaves of bread or whatever it might be. They're going to eat higher quality ingredients and have better glucoses. Hey, that's awesome. So yeah, the data exists, and I couldn't sell them on it. And I think that's just because of the inertia in healthcare.
Wow.
They're stuck in their ruts, and it's obviously it's a very pharmacology heavy healthcare setting. If you want quick results, here's the medication for that, right? That's how you get someone out the door in 3 days or whatever it is.
Wow.
You got to have some. You have to have a quick intervention, and so it's always about medications. I feel like a glorified pharmacist when I'm working in the hospital. it's very strict. If there's a problem, here's the solution, and it's always a pharmacologic solution. Here's the standard of care. Give this medication.
Wow. Now, I want to go back and revisit something that we talked about earlier. You said you found all of this out in 2014. It sounded like nobody had to teach you this, but what was it about you? Was it common sense that you were looking at diabetics and seeing what they were eating? Like, how were you able to make that connection when seemingly no other doctors make that connection on their own without learning about things like low carbohydrate or seeing the research that you were actually doing?
It's a good question. What set me apart from every other doc? I think, part of it is I do have a mindset of challenging the status quo and, staring at this problem like, hey, something's not working. We have this patient on the standard of care for diabetes and his glucoses are still 300. Something's got to give. You got to look for a better solution. So it really just started with that curiosity of, I approached the situation with the intent of finding something to fix. That was the performance improvement project, right? And I guess it opened me up to the possibility of there's a better way to do things. So let's go look for a better way, or something that needs to be done in a better way. And that I can't tell you exactly where the train of thought in that moment, except for, hey, everybody knows, at least I think, that carbohydrates increase glucose. And here's this guy who's diabetic. By definition, he's carbohydrate intolerant. We just gave him a bunch of carbs. Now his glucose is 300. This seems to me a very logical point of attack.
Yeah.
So I don't know why this is not happening on a bigger scale among other docs. Take this, for example. When somebody has a low glucose in the hospital, what do you think they do? They shove them full of sugar.
Right.
Right? Here's some orange juice. Oh, here, eat some cookies, eat some crackers. Or if they can't do that, you just shoot them full of dextrose, glucose, in the IV. That's the quick fix. So if they're unconscious, can't eat, just give them a shot of E50. Okay. So everybody knows that you treat a low glucose by providing sugar or carbohydrates. So why don't we know the opposite? That if you wanted their glucose to be lower, maybe we shouldn't give them as much, right?
I mean, I've been in the low carbohydrate space for a while now, and so that seems really obvious. Maybe it was less obvious when I first got into it, but the way you're explaining it, pretty much a 5-year-old should kind of identify that and think like, well, yeah, if there's too much of something, let's have less of that. You know what I mean? Like, it seems like it would be really obvious, but it's so complicated because it's everything that you're saying. The hospital systems, the government recommendations, nutritional guidelines, everything is against that one so simple thing that people don't make that conclusion very easily.
Right. An added piece to it, well, I kind of touched on it, is being that insulin is the standard of care as defined by the American Diabetes Association, the so-called authorities. There's this perception of liability if you stray from that guideline. And I think that strangleholds a lot of clinicians in terms of, even if they see Dr. Stadtherr over there playing with this carbohydrate restricted diet, and, oh, I hear good things, and they may see my patient's glucoses look better than theirs, they're still uncomfortable. For whatever reason, they're not willing to be bold in their stance as basically the boss of the situation. You're the attending. You can do whatever you want as long as it's not cavalier. I found that, thanks to Dr. Westman's papers and several others, the data was abundant enough and strong enough that I was doing something that was very defensible. And I didn't feel that I was at risk in any way.
You were comfortable. You felt very comfortable saying the things that you were saying.
Absolutely. I had basic science on my side. I mean, the most basic science possible. Low glucose, give them sugar. Well, come on. If you want someone's sugar to go up, you give them carbs. I want their sugar to go down. How about we not give them carbs? Right? So from that standpoint, as well as having the evidence that simply dietary carbohydrate restriction as the first line in treating diabetes, holy cow! I mean, that was a landmark paper to me that said, yeah, this is a good intervention. It's an effective intervention. It's safe. There's no evidence of harm. I felt completely comfortable taking the approach that I did.
Wow. And very uncomfortable in the setting that you were in, to the point that, I mean, I don't know, like when you start to see results on low carb, you really can't unsee that. And that would be, again, very uncomfortable for you in that setting. You decided to branch out and do something more unconventional. It sounds like it suits you perfectly. Tell us about the story of you kind of stepping out of the hospital setting. I know you said that you take some shifts every now and again, but it's not as much your day to day. You created your own thing. Tell us about that.
Yeah, so my interest in metabolic health was obviously spurred by this event, and then continued research on metabolic diseases. And while initially the interest was in diabetes and how that was managed in the hospital, it quickly spilled over into realizing that 80+% of what I'm doing in the hospital and what we do in healthcare every day is the same damn disease. It's insulin resistance. There isn't a separate heart disease, vascular disease, stroke, dementia. Dementia's complicated. Fatty liver, obesity, hypertension, all of these things. It was that, so through my research, it was that realization that all of these problems are driven by insulin resistance. And yet we treat them so amazingly different in the hospital. I mean, it's crazy to map it out and see how differently each one of these things is managed, when it could all come down to a really standardized insulin resistance treatment wipes out everything, right? So there's this analogy of a tree of insulin resistance and all these problems, which when you're looking at it, like, oh yeah, well that's everything we do in healthcare every day, and it's all the insulin resistance. So you treat the core problem, and the whole tree benefits. Whole tree gets better. So that realization that really we're targeting insulin resistance, i.e., metabolic health, along with the realization that patients wanted this and it was beneficial to them. And these people wanted to follow up with me when they left the hospital. I'm like, sorry. Once you leave the hospital, we're done. No more patient-doctor relationship. But they were demanding it. And so some of them would email me and send, I would tell them like, all right, general questions only. I can't really target your specific situation. But they would send me feedback too, and just really cool stuff. Like, hey doc, do you remember me? I was in the hospital, I had a stroke. I've also had these terrible migraines. Well, I listened to your advice. 6 weeks later, I'm off of my 40 units of insulin, completely off insulin. And my endocrinologist agrees. Like, hell yeah. So I started getting these sorts of feedback from people. And I realized there was a great need for a service like this in the community. Don't wait until they're suffering a complication of the metabolic disease. Let's hit them up front. Let's proactively address this metabolic health before they end up in the hospital. And there was a poignant moment for me. And so I had this patient on my list one day, 45-year-old guy, former Division I collegiate swimmer. So athletic guy. And he was on my list with a stroke, confirmed stroke. We saw it on the CAT scan when he got admitted. No other medical history. And so I see this patient on my list. I'm like, come on, 45. I was like, I think that was only 1 or 2 years older than me at the time. And I started digging through his chart, like, why, with the question, why? Why did this guy have a stroke? This doesn't make sense. And long story short, he had been pre-diabetic for 5 years prior to this, and well documented in his electronic record. Every year, fasting blood work, glucose over 100, not terribly, like 106, 109, but it's pre-diabetic. It should have gotten someone's attention. And so I go into this meeting with, or this rounding on him. So I go into his room, and sure enough, he says, "Doc, why did I have a stroke?" And thank God I was prepared. I had done my research, because I had an answer for him. And so I explained it to him, and I said, all right, well, did your doctor ever talk to you about your fasting blood work? Like, no. Well, yeah, they said it was normal every year for the last 5 years. Told me it was normal. Like, well, I hate to break it to you, but here's the reality. It wasn't normal. And I am horribly sorry that nobody addressed this for you. And so I vowed that is something that should never happen. And that has become one of my big focuses, is the early detection, accurate detection, and transparency, basically, of informing people that they have prediabetes. Like, let's get on top of this. It's one of the early signs before they develop a complication. Unfortunately for this guy, he went straight from prediabetes to having a stroke. Terrible luck. But that's the way it happens with some people. And so, long story short, the circumstances were as such that my days in the hospital were limited. I didn't want to keep doing it because corporate, etc. As you can imagine, working for the man, it's very draining. And so I realized I need to start this clinic. I need to make this happen. This has been a dream of mine for years. And it was getting closer and closer to what it would look like. And at some point, I came across this direct care model of care, of healthcare, where it takes the insurance company out of the picture. There's no insurance middleman telling you what to do, how to do it. It's a pure patient-physician relationship. Nobody else is in the exam room. So any decisions that are made, it's either me, the patient, or the collaboration between us. That's the only influence. So it's a cash pay practice. And so my practice is called Revitalize Metabolic Health. And basically with the intent of the message of it's time to revitalize how our health, our health status, and focusing on lifestyle as a big part of that. And so I'm focused on all things metabolic health with this practice. The majority of people that come to me are seeking weight loss. I have several diabetics though, which was really, I envisioned that being more of the population, and it's growing. So more and more, but definitely, people are most concerned about weight loss. It's the outward visible manifestation of insulin resistance, right? And then over time, I've also incorporated primary care in a direct primary care model. Again, keeping the insurance company out of the picture. So for a low monthly fee, you get full access to me, and we address all things primary care. And so part of the reason that primary care piece came in is, as I mentioned before, 80% of what we're doing in healthcare is metabolic health. Yeah, there's a few other things like trauma or some routine infections. Although propensity to infection, it turns out to be related to metabolic health.
Yep.
Shocker. And so you dial in your metabolic health, you're not going to get those routine colds as often. Sure, they're going to happen, but much less frequently. And so many things are tied to the metabolic health. I thought, you know what, I'm already doing the 80% plus of healthcare. Let's do the primary care too. And it's a good service for my patients. They love that. so that's how I transitioned out of full-time hospital medicine. And I'm doing less and less shifts in the hospital. I should be out of the hospital in the next few months, actually.
Wow, that's gotta feel amazing. Wow.
Yeah, it's
Wow.
pretty exciting.
Okay. That's so amazing, and so happy for you that you found something different. Whenever I hear a system like this, we talk about systems in the medical system, and the financial feasibility of doing different things. I want to know, is your current practice financially feasible for yourself and also for your patients?
Absolutely. Yeah. Now I'm still growing my practice. It's very close to being self-sustaining, or I should say, to cover my bills, let's say. It's as with any small business venture, it takes a lot of work to get it off the ground and get it to a point where it's running full speed. It's like you hear about doctors coming out of med school and residency saying, I didn't learn a stinking thing about marketing or how to run a business, which is absolutely true. Because let's face it, you're being trained by the system. They want to keep you in the system. That's where they want you. They want you to be an employee. They want a pawn of their system. So they're not going to teach you how to be independent. That'd be crazy. So all of this has to be learned on your own. I think direct care, especially direct primary care, is the future of healthcare. As people are realizing that insurance costs are spiraling out of control, you're getting less and less for more and more. The role of insurance in healthcare, I think, is going to be looked at very differently over the next few years. It's happening now, especially as we see exploding numbers of direct primary care clinics around the country. There's over 2,000 right now, which is really, really awesome. Yeah,
great.
It was basically unheard of 15 years ago,
right?
And now there's 2,000 and they're thriving.
That's fantastic.
But insurance doesn't equal healthcare. You can get quality healthcare outside of insurance, and having insurance doesn't guarantee that you get quality care. So it's really important to understand that those are very different things. Basically, if you want quality care, you need to get outside of the insurance model, because the insurance model says, hey, we need this clinician to see as many patients as possible. So, we're going to schedule appointments every 10, 15 minutes. And then there's all sorts of things that come up. Nobody can stay on that schedule. So you're lucky to get 7 minutes, maybe 10 minutes face-to-face with your doc. It may not even be your doc. It's going to be whoever's available at that point. You have an acute issue? We'll get you in 2 weeks if you're lucky. Well, what good is that? That doesn't help anyone. Here in my model, the direct primary care model, people could get in the same day. Next day, I reserve spots for same day appointments. Like, you need to be seen? Come on in. I'm here. I had a guy texting me on the weekend with an issue that couldn't wait. Took care of it on the phone, even though I was out of town. So these things are possible. There's great things possible once you get outside of the insurance model. There's amazing discounts on medications because I can buy them wholesale, pass the savings on to my patient. Labs, same deal. Wholesale rates on labs, huge discounts. Imaging, same deal. Because DPC docs set up contracts with the labs, the medications, the imaging, so they get exclusive rates. Healthcare doesn't have to be expensive. Insurance is what makes healthcare expensive. When you ask your insurance to pay for it, it's going to be expensive, and you're probably not going to like what you get because it's going to be on their terms, not yours.
Hospital is not throwing you a parade. I'm going to throw you a parade. I'm going to name a day out of the year after you. This is amazing. I get so pessimistic when I hear all the details of what's really truly going on out in the world. And then I hear stories like yours. And I get so hopeful that this will find the right people at the right time. And if so many people start coming to you and have amazing results and are really happy, that message is going to spread. And it's just so cool to talk to people like you who learn this stuff on the fly, on the job. You weren't necessarily taught this initially. You got curious, you asked some questions, you explained all of it to us in a way that, again, I would argue a 5-year-old could understand today. It's so wonderful. It's so cool what you're doing. I'm so glad I got to meet you at Low Carb Denver. I'm so glad you're doing what you're doing. It sounds like, it is going to be a process. Running your own business is not that easy. And it's definitely building the plane as you're flying it. But to hear that it's a viable option for your patients and for yourself, and to know for sure that your job satisfaction must be through the roof, actually helping people. You can sleep at night, regardless of whether you're making as much as you are, were at the hospital. I think it's so cool. It's so savage. I absolutely love it. Dr. Chris Stadtherr, where do you want people to go to find you and connect with you and your work?
Yeah, thanks a lot, Casey. I appreciate what you're doing too, getting the word out to people. It's super valuable.
We got to do it.
Yeah. So my website's Revitalize metabolichealth.com. You can also get there with a simpler one, rmhgh.com. The GH is Gig Harbor. And then Instagram, Facebook, YouTube, even TikTok. Post some
nice.
Post some videos up on all those, or all sorts of social media content.
Nice. That's great. Well, I will follow you on social media, and hopefully one day I will see you either playing ice hockey or ice fishing.
Sounds good. Maybe we'll meet again at Low Carb Denver next year.
Yeah, there we go. No, that would be great. The stories that I hear from a wife spending time up at her cabin in Wisconsin during the winter ice fishing, like literally sitting on a bucket, not having a hut, sounds absolutely frigid. So if you can avoid it, it sounds best. Just continue to avoid it. If you made it this far in life, you don't need to at all. Dr.
Right.
Chris Stadtherr, thank you so very much for everything that you are doing. It's so wonderful to hear people step outside of a paradigm that's not working and actually help people and have that job satisfaction. It's endlessly cool. I think you are endlessly cool. And thank you so very much for taking time out of your busy day to spend some time with us and educate us on all the stuff that you're doing at Metabolic Health. We really, really appreciate you.
Thanks. I appreciate that.
Absolutely. And this has been another episode of Boundless Body Radio.